So we're going live with Amanda Olsen with Intimate Rose. She's a pelvic floor physical therapist. And I'm super excited about talking about return to running. So hello, everybody. I'm actually going to turn comments off just because we're going to have this on YouTube. And it's a horizontal format. And then if we have comments on, the comments are in one of our faces. So it doesn't look great. So give us just a minute to get connected here. And I'm going to send her an invitation. And I think we're set here. Yes. Amanda, it's so good to see you.
It's so good to see you too.
Thank you for taking time out of your day.
It's my pleasure.
And imagine, I mean, look at all the questions that we got. So we have some basic information that we're going to cover, and then we're going to cover as many of the audience questions as we can. But we just don't have that much time.
Absolutely. Never enough.
I know, there's never enough time. So before we get started, can you give us just a little bit of your background?
Absolutely. So I've been a pelvic health physical therapist for over a decade now, over 10 years. I'm certified through the APTA as a CAPP certified pelvic floor provider.
Great. And
then also through Herman and Wallace, the PRPC certification as a pelvic health provider. I've been in clinical practices ranging from hospital-based outpatient to private practice. Additionally, I'm the president and chief clinical officer of Intimate Rose,
Yes.
where I make pelvic health devices and create educational content. And I'm also an educator now. I wrote my own course for the American Physical Therapy Association on pelvic floor dysfunction in runners.
I love it. I love it. And you spoke at Combined Sections meeting this last year. It's such a good turnout. There was so much good feedback on that. So it's such an important topic, and so many people want to know, they want to keep their bodies safe. So let's just jump right into it. When is it safe to return to running after baby?
Absolutely. So we have these brand new guidelines, which I know that you posted and a lot of your viewers have read, which essentially utilize the evidence that we currently have along with evidence that we know about healing and tissue healing after any kind of injury. And spoiler alert, birth can be associated with injury.
Yes, yes.
And so what the guidelines are showing, and what I've seen anecdotally in my clinical practice, is that somewhere around 12 weeks is a safe point where we know that the tissue has healed to begin running again. That's a bubble, that's a window of time, and everyone heals differently. We have unique traits about our own genetics as to how we heal. Every birth is different. Every birth is different. And women that have had C-section, they had the pressure on their pelvic floor of that pregnancy, and maybe even they went into labor and were trying for a vaginal delivery, and then we add surgery on top of that, which is what a C-section is. So all of those factors could create a little bit of a longer window. And, if it's a relatively uneventful birth, somebody may get back to running a little bit earlier. But the big key thing is you're ready to run when your body is ready to attenuate the forces of running. And so what that means is your body is ready to accept the impact of each and every step. And we know that with each and every step, we're getting about 2 times our body weight coming through our foot and up into our pelvis and our low back.
Right. And so we've got to have the pelvic floor has to be able to counteract that force from below. And so if those muscles are weak and stretched out and that tissue can't accommodate that extra force, you may not be ready to run yet.
That's exactly right. Pelvic floor needs to be able to accept that kind of pressure. And then on top of that, we need our abdominal muscles to also be ready and to have timing and coordination with the pelvic floor to protect our low back and the rest of our trunk.
Yes.
Because the pelvis, I'm so egotistical that I think the pelvis is the center of the universe.
But we have other joints too.
We do, yes. We've
and
got
other structures that need to be supported.
Exactly. We've got knees and hips that need support. The rest of our trunk and coming up into the neck needs support so that every time we run, we're not having to re-exercise. Those kinds of things.
Good. Very good. Okay. So what is the safest way to ease back into running?
The safest way to ease back into running is to, as soon as possible, start retraining the pelvic floor muscles. You know, you can start doing pelvic floor activations, also known as the Kegel, in that hospital bed or in your own bed or wherever you are, starting the foundation of coordination. You know, being able to contract and relax is something our muscles knew how to do at one point, most of the time.
Right. Whether you knew they knew how to do it or not, it might have been automatic.
Exactly. And so we need to reteach them not just power, but endurance and coordination, because after a delivery, depending on how that baby's sitting on nerves or, you know, what happened during that delivery itself, there can be a disconnect between what the brain says when the brain says go and when the pelvic floor is able to receive that message, understand it, and do it.
Yeah, exactly. I mean, think about if you had a knee surgery and all the swelling and weakness and issues there, and apply that same concept to the pelvic floor in a vaginal delivery or C-section.
Exactly. Yes, exactly. So we can start with laying that groundwork right after birth and progress it to more functional type activities. So we know we're ready to run again. We know that we're able to contract and hold for 5 to 10 seconds and do that repetitively, when we can do things like step down off of a step. So in preparing, you can be training the pelvic floor muscles to contract and step down and accept that kind of body weight without experiencing leakage or pressure. All of that is to say that when we actually do go to run, it still can feel very, very different.
Yeah, and there's a lot to do before you actually run.
Yes, exactly.
Okay, so what do I do about leaking when I work out or run? Is it even a big deal?
Yes. It is a big deal in so much as we are bothered, and is that it's a signal that just is telling us.
It's a warning sign that all the team, it's a team, right? And some of the team isn't working.
Exactly. You know, that's exactly what it is. It's a warning sign. So should you be bothered, don't be frightened. And, you know, there's one of the things that I learned 10, 11 years ago from an amazing instructor was to say that we are going to address the pelvic floor. We are going to get stronger, but pad up and play on.
Exactly. So, is that MJ?
Yes, it was MJ.
Yes, I know. Yes, she's amazing. So we want you to move. We want you to walk. We want you to do activities.
Exactly. Yep. So there's no need to withhold running because you're leaking. But you know, we still want to be using the pads as a Band-Aid. They're there for a reason, so that, you know, you can do things without having urine everywhere. But in the meanwhile, we're working on addressing the problem.
And okay. So what is that sense of heaviness that I'm feeling after a baby, and why is it worse during my workout or at the end of the day?
Yes, so a sense of heaviness in the pelvis, generally associated with pelvic organ prolapse. That's a product often of some weakening of the pelvic floor muscles, and sometimes a little bit of strain and perhaps injury to the ligaments suspending those organs. So what they do is they just drop into the walls of the vagina, and sometimes you can feel kind of a ball or a sense of laying an egg, for lack of a better imagery.
And we don't want to lay eggs.
No.
But
so
it happens. It's far more common, and it's not that scary. It is possible to have a good, healthy, quality life.
Exactly. It's so true. What we want to do is we want to stabilize the prolapse. So step one, seeing a pelvic floor physical therapist to get a thorough examination. And we can be stabilizing that prolapse while, again, we're working on strengthening the pelvic floor to create a lift. We have great evidence on MRI studies that show that pelvic floor strengthening can reduce prolapse by 1 to 2 grades.
Yeah.
With most of the time,
exciting?
Get it up and in there.
Yep.
And in the meanwhile, a pessary that's fit by a well-trained individual can be really helpful. Pessary being a little device, they're usually medical-grade silicone. They come in all different shapes and sizes to address different forms. I'm a big advocate for them. They can really get a woman back up and at 'em while she's working on preparing her body. And then disposable things on the market. You can put a tampon in to help stabilize the urethra. Bulge coming in through the back, being a rectoseal, and then poison pressa is another cotton device, goes in like a tampon, but it's not a tampon. It's going to create kind of a pressure in all directions so that it helps stabilize.
Yes. And then external support can be very helpful too. So,
yes.
mhm.
Yeah.
The shorts, the EVV shorts, I love those. You know, I'm new to them in this last year, and they have built-in perineal support for me. I'll send you the link. You need to
Ooh,
check them
yeah.
out. I think it's a UK company, but they're really incredible. So
Awesome.
basically, the pelvic floor doesn't have to do it all alone. There's ways and strategies that you can give some internal extra support or external extra support. And I'll be happy to share some links on my story after this. And if you guys have any questions, I know you'll answer and I'll answer. We love to talk about this and we want to help you. Okay, so how do I know if I have a diastasis, and is it safe to run with a diastasis?
Yeah, so diastasis has been such a hot topic lately.
So hot.
Yeah.
Yes.
And another spoiler alert, 100% of women get a diastasis in the third trimester. So
because you're stretching, your tissues are stretching, so they've got to give. Something's got to give, right?
exactly, something's got to give, and it ends up being that tissue in the front. We get that little separation, and again, according to genetics, according to our activity levels, you know, how we lifted and all that. That may stick around for a little while after pregnancy. And there are whole philosophies on how to manage diastasis. Sometimes there's belting, sometimes there's bracing. I think we can all agree that retraining, transverse abdominis, and pelvic floor to help provide some closure.
And some support there.
Yep. And then all of that is important for intra-abdominal pressure, which is going to be a product of our trunk and how it's supported by the abdominal muscles and the back muscles and pelvic floor and the diaphragm. So the dependence on being able to run with the diastasis is going to be dependent on the grade. And for that, I just recommend seeing a pelvic PT.
Yeah, exactly.
To get
some guidance.
Exactly. Yeah. Measuring at home, I think, can throw out all kinds of red flags. And there's a lot of different information on the internet about what's safe and what's not. So it's really just generally.
It really is. And it's evolving. You know, I think this is rapidly evolving. So if someone wanted to have a brace, so what are some general recommendations? We want it to be flexible and to be able to give. You know, my 13-year-old daughter sent me this belly wrapping Instagram post this morning. I'm like, oh, well, that's interesting. Because she's like, Mom, what do you think about it? I'm like, well, it's interesting. So we want to give, and I love that she's talking about it, right? Thank you. Thank you. The message is getting through.
Yes.
And my teenagers are talking about it. So we want to give some external support there as needed temporarily, because we don't want to have to wear a brace or a band for the rest of our lives, right? We want to strengthen, but we don't want to create too much pressure that it's putting increased pressure on like pelvic organ prolapse. Because think of a balloon and you're squeezing that balloon, that pressure's got to go somewhere. Unlikely that it's going to go up against gravity. It's going to go down where you're weaker and gravity is helping it go down. So flexible, stretchy, but still supportive and temporary. Those are some of my keywords there.
Totally agree. Sometimes the pressure can go up too, and patients are vomiting from having.
Oh yeah, and so they could have it both ways.
Yeah.
Yep. And those waist trainers, no waist trainers. Okay. So my body feels different overall when I run now after a baby, and I feel less coordinated. Why would that be?
Yes. So again, remembering that every cell in our body changes when we are pregnant and again after we have a baby. So the hormone relaxin that we have while we're pregnant is gone 3 days after we deliver. So
3 days.
3 days, yeah.
Okay.
So it clears on out. It recognizes there's no more need for expansion. But with that low load, prolonged stretch of pregnancy for 9 months, we do have elongation of muscles in the abdomen and in the pelvic floor and the tendons and the ligaments. So, you know, even in the hips, even in the knees, things are not as we left them prior to becoming pregnant.
Right. You can't just expect to jump back into it.
No. It all takes retraining. And so when that first time we go out for a run, some of that timing, coordination is lost, and also the strength and stability around the other joints. Our feet get, you know, our arches start to collapse because the elastic
and kind of spread out.
Yeah, exactly. And our foot being the first thing that hits the ground when we run, that kind of sets the tone as well. So recognizing changes in the feet, strengthening the feet with little foot scrunches and things like that.
Nice. I like it. Good. Okay, so what cross training is safe to do with the baby?
Yes. So an interesting thing when we are talking about running, so according to true running protocol, cross training is going to be considered anything that is in direct service to our running. So, as a physical therapist, I think, core stabilization and bridges and those things are cross training, but they're not. They are core training and stability. So cross training would be use of the elliptical, swimming, use of the rower, those kinds of things.
Okay, good. That's a good definition. Mm-hmm.
Yeah.
Mm-hmm.
Yeah.
It's helpful to define the activities.
Yeah. When I did my running coach certification, I'd already been a PT for like 9 years. And when I came in and learned like how the running community views cross training, it's very, very specific. It must be in service to running. And so with the baby, those swimming, so awesome. Use of the elliptical is going to be fine, but recognize that most ellipticals are made for people that are 5'4" and above. So short people like me, dragging down the average, that stride length is going to be really tough, especially on an open new pelvis. Yeah. So if you are petite and small, maybe avoiding the elliptical right away. And sticking with the rower, or something like that, or foot drills, plyometrics, things that are going to help train you to be able to be more ballistic.
Good. Excellent. Is it a good idea to run with the stroller?
Yeah, it's so tough. Here's my thing.
It's tough.
It's not ideal, but I am a runner, and I can appreciate that may be your only window of time that you get is with your stroller. And if you don't go for your run, your head might explode. Yeah. So
you've got to weigh the pros and cons and the benefits.
Yes.
And
It's exactly right. So we can say as a disclaimer, not ideal, but if you're going to go ahead and do it anyways, you can ensure that you're ready by training some of those motions of pushing the stroller. So a couple things would be when we push a stroller, we're exerting force through our wrist, elbow, shoulder in single leg stance and in double float. So running, so different from walking, we're either on one foot or we're on no feet, because we have that moment where we're in the air. So all that force is going through the upper extremity,
upper body,
the core, and then the back. So if you're gonna run, you need to do drills and be practicing and strengthening in service of that. So what I recommend is standing in single leg stance, kind of like a little stork, and practice either with a handheld weight, just pushing forward, bringing it back, with a Kegel and with the core control. So that's one drill. Or with a band secured behind you at the door. I'm doing this.
Yeah, no, it's good. I see it.
Yes, and you're practicing pushing forward with the breath so that you're training your body to be ready for that. And I recommend doing that before you start running.
Right, that's good. And so if you're having pain and leakage and prolapse with even the pre-running things, you may need to spend some more time there before you're jumping straight into running.
Exactly. And it's worth it. It's worth waiting. I know it's so hard. I mean, running is my drug of choice. That's why I do this.
You're passionate about it. That's good.
Yes. And for so many women, it's not just like that thing they do that's fun. It's like their thing.
They've got to do it.
Their moment. Yeah. And so we can, as physical therapists, we can serve them better if we recognize that, like, we can't necessarily take that away, but we can train them to be ready for it.
Yeah. And maybe once they are, it's not like you have to run 100% of the time, right? You can do some intervals, walk, run, and speeding and hills. I mean, there's so many either ways to make it easier or harder, right?
Exactly. Alternating arms every block or every other block, or setting a timer 1 minute, 2 minutes, because that arm, your good arm, is going to get really tired, and that fatigue will become more systemic. It is a lot more energy to push that stroller. And if you can get a girlfriend that didn't just have a baby to join you,
to go with you,
and help.
So when they ask, what can I do? Come with me. Or watch my baby while I go.
Or watch my baby and give me 5 hot minutes to myself.
Exactly. Yes. Okay. So the only time I get to run is with a stroller. What is the safest way to do this? I think we covered that.
Yeah.
I've been back to running for a while now, and I have a weird, deep pain, kind of in my hip, kind of in my groin. What do you think it is, and what do I do about it?
Yes, so something interesting. Oftentimes postpartum, we think of a hypotonic or a underactive or a weak pelvic floor. Those are all a bit synonymous.
So basically too stretched out.
Yeah, exactly. what can happen is women can be getting stronger, and depending on how they're running, if they're running on the same side of the street all the time, running with the stroller, etc., is that certain running mechanics can create a too tight sensation on one side of the pelvis or the other, sometimes both, and we can get trigger points that are like little knots, the same way you get in your neck or your shoulder, that are painful. But interestingly, those trigger points in the pelvis are hard to explain. They're very nebulous. And sometimes it's like, it's kind of in my groin, but it's kind of in my bottom.
Yeah. Good.
You know, it's hard to get to. And oftentimes it's because of the obtruder internus. And so it's, go ahead.
Those muscles are trying so hard to do their jobs, right? They're trying, but they've been stretched out and weak. And so, like, think about, I like to use an example of like a receptionist. If she's on the phone, like you feel her upper trap at the beginning of the day is nice and loose. End of the day, it's rock hard. That doesn't mean she got stronger through the day, right? The muscles just didn't have the strength and endurance to do what they were asked to do. So that's same concept with the pelvic floor.
Yep.
Good. Okay, so I had a C-section. Any tips for getting back into walking or jogging? 7 weeks postpartum.
Oh, yes. Okay. So with C-section scars, first thing that we want to be doing, first thing we're doing is addressing pelvic floor, because you didn't get out of having that strain on
you
the
still
pelvic
might
floor.
have some dysfunction.
Exactly. And then secondly, addressing the scar tissue from the C-section and doing some graded, you know, initially can be very tender, especially for a lot of women, so sensitive. So sensitive. And so you can
a lot of times they don't want to look at it, touch it. They've been avoiding it.
Yeah.
And it might even be years later. You know, we've seen people years later that are still completely avoiding their C-section scar. So you're at a good spot, usually 7 weeks, you know.
Exactly.
As long as it's healed.
As long as it's healed, it's closed, you know, you've gotten the green light at your 6-week follow-up appointment from your birth provider. And the women that have older C-section scars, those are, we can still get those mobile no matter how old. But at that 7-week mark, you can come along with a makeup brush and just gently start brushing it to desensitize it. And then just really gentle soft tissue mobilization. Because what we don't want to do is have a lot of scar tissue right over the top of the bladder. So the bladder lives
right there.
Yeah. That scar tissue, depending on our genetics and depending on, you know, what happened during the C-section, that can kind of compress and in some cases kind of grow into the top of that bladder. And then every time we run, it's bouncing up and down on top of that bladder. So you can strengthen until the cows come home down here on the floor, but that compression is still working against you. So softening the scar and practicing contracting. So often after that C-section, we're hesitant to want to contract because it hurts, and we're not supposed to for a long time anyways. And when can we do it again? So re-strengthening, retraining those abdominal muscles.
Good. I love it. Breastfeeding. So can you talk about the impact of breastfeeding? She did pelvic floor PT, but wasn't able to run again without pain until she weaned.
Interesting. Yes. So then we get to blame estrogen and progesterone.
The hormones.
Yeah, that's exactly right. So while we're breastfeeding, we're in a low estrogen state. What that does, interestingly enough, systemically, we don't have a lot of blood flow going to the vaginal tissue, tissue around the urethra, tissue to the pelvic floor. So that can create discomfort, pain with sex, pain with wiping. And because we're getting a little bit less circulation, sometimes people just have a harder time getting that contraction. So I can totally see why that happened. Yeah. Sometimes using a finger to help guide it in there and just a little bit of soft tissue in the vaginal mobilization in the vaginal wall can help with that.
Good. So this question, how old should your baby be for running with a baby jogger? So do you have a maximum limit or minimum limit?
So totally dependent on what kind of jogging stroller you have. Many of them have the awesome capability to buy an extra bar so you can clip their little car seat into it.
Stabilize it.
So they're totally stable. That's what I had. I had a bob, and you can just clip the car seat in, and they can really go when you're ready to go. So 3 months because they are in their car seat. If you don't have that capability and it's just the jogger and it's the harness situation, it needs to be about 8 months. What you're looking for is your baby able to sit and stabilize their own spine and their own head? because they're going for a workout too, because it's lots of stabilization against your running.
Yeah.
And
bouncing and
yes, and they need to be able to withstand that without getting injured in their little necks. So I just recommend stabilize that baby as best you can. Wait till 8 months where they can hold that trunk. And the other thing is, be very, very aware of transitions on sidewalks, because even just that little bit of impact of that stroller hitting, you know, just a 1-inch lip can really throttle.
Like a kind of a whiplash.
Yes. It's almost like a car accident for them. So really stopping, pop a wheelie, get the scrubs. Yeah.
Very good. I love it. Okay, so I have a grippy pelvic floor, maybe gripey. I have a gripey pelvic floor in some areas, but I leak when running once I fatigue. So any suggestions there?
Yes, I read it as grippy too. So I think she's thinking that she has maybe a little bit of overactivity.
Yeah, I'm thinking that too.
Got some leakage.
Right.
So there's two things that I can picture without having assessed that person myself. The first would be a grippy pelvic floor often is not flexible. And so again, 2 times your body weight, bladder sitting here, pelvic floor sitting here. With every bounce, we need this ability to shock absorb.
Like a trampoline. We need to go up and down.
Yep. We need flexibility there. So if it's grippy and we're going like this, there's that opportunity for a little bit of urine to leak out. So in that case, obviously recommending pelvic floor physical therapy, usually looking for trigger points and retraining the pelvic floor to be able to relax and to contract maximally.
Yes. And then be coordinated to do it at the right time, right?
Yes. Timing is key. And that's so hard. And that takes much longer than people realize, is that it's like learning how to ride a bicycle again, or learning how to juggle.
It's so much more than Kegels.
It is. Yeah. And the other thing that could be happening with her is that the pelvic floor coming from the tail, so if this is a side view, coming from the tail to the pubic bone here, it's possible to have tight grippiness around the anus in the back and a little bit of weakness in the front where the bladder is trying to.
Because there's different muscles that make up our pelvic floor.
Exactly. So that person, again, recommending pelvic floor physical therapy, but it may come down to posture and getting that pelvis forward a little bit so that the front fibers can contract around the urethra.
Good.
That leaking.
Yep. Yeah. And practicing working the front and the back and the discrimination there, right?
Yes.
Very good point. I love that.
The cue that I give my patients to get the front fibers are to imagine that the urethra is a telescope, and that gets them to just focus on those fibers.
I like that.
Works good for men too.
That's good. Is there a certain way to use the feet to maximize support and alignment?
Yes. And I actually teach this in my class, how to use feet for several reasons. There's so many reasons. One, the nerves to the feet are from the same nerve root as the pelvic floor. So S2, 3, and 4 from the sacrum innervate and they help control the pelvic floor muscles. They also go to the lumbricals in the feet.
That's why sometimes when we squeeze our pelvic floor, we squeeze our toes.
Yeah.
Kind of an automatic response for some.
Yes. And I use that as a party trick when people have to sneeze and they are not yet to the point where they can withstand it. I'll have them punch their toes to get that overflow.
Nice. That's good. I like it.
And then the other thing is that we already talked about is that the foot hits the ground first. So we need a nice, strong, but flexible foot to stack the rest of the body on. So the way that I use the feet is we kill 2 birds, 1 stone. I have them contract the feet in a little foot scrunch fist, if you will, at the same time they're doing their kegel and exhaling. So inhale, relax, exhale, and
good. I love it. That's great.
Yeah.
Okay. We have more questions, but I think we covered them really. Do you have any resources for patients? So anything that you can point people to, and also providers. So there'll be pelvic health therapists. Please give a shout out for your courses. I know you're teaching one for the Section of Women's Health, which is fabulous. Anything that you want to give in terms of resources and Intimate Rose too. What products might you have that might be able to help?
Absolutely. So on the Intimate Rose website, under the video section, I have videos ranging from different teaching incontinence, teaching pelvic floor release. I have a couple videos on exercises specifically for runners that are pelvic floor and core. And then tools and devices. We have Kegel weights. If you've seen a pelvic and you know that you've got a good contraction, that's a great way to strengthen the pelvic floor to be stronger, to withhold that strength.
Because it's giving you some resistance. We use weights for our biceps and our legs. Why not the pelvic floor?
You've got it. We've got dilators, a wand for trigger points, so designed to come in and get obturator internus in the side of the hip. And then lots of blog posts. And then my course is actually all over North America. It is through the section. I'm doing it privately too. So for providers. Yeah. 2-day course.
Excellent. Excellent. Well, you have such an amazing content and such an amazing spirit. You know, when we met a couple years ago at Combined Sections in New Orleans, we were right next to you, and you guys were so helpful and friendly when we were just starting out. And I think we're just going to be lifelong friends, and I love collaborating with you. And I look forward to seeing you again in February in Denver.
I can't wait to see you in Denver.
Yes. Anything else that you'd like to share with people before we close?
No, just, you know, you can visit the website. There's resources for patients, providers. You can apply to be in our network, and you'll get my research reports and all of those other valuable
very helpful information. She sends out some really nice case studies in an email format that you can, it's helpful as a provider, but then also as a patient to see real life examples of how pelvic health applies to people. So excellent. Keep it up. Keep up the great work. And thank you, everybody, for joining us. Thank you, Amanda. Appreciate you guys. Take care.
Thank you so much.
Bye-bye.